So for the follow-up of renal failure is divided into clinical means and paraclinical means. And to follow up, you still use the SH all the way algorithm. You start by follow-upping the disease, which is renal failure. Renal failure can be followed clinically with the urine output. You measure the urine output of the patient per day, and then paraclinically is going to be measured the creatinine that you can do per day or every 48 hours. You measure the complication. So you measure the complication, you follow up the complication, like pulmonary embolism, you have signs of respiratory distress and all that. So pulmonary edema, sorry. So you have to measure all that. You see that clinically, and paraclinically you ask for chest ray to verify if there are still signs of the edema on the chest X-ray. You have the next one also, which was the anemia. So you have the next one, which was the acidosis that you had to visualize on the you have to visualize. So you can ask, say, acidosis, you can see for signs of acidosis that you have, or you have signs of acidosis clinically, and you have to ask for the paraclinical investigation. For the hyperkalemia, you ask for the irregular pulse if you try to find for it, and paraclinically you do the investigation. So based on the complication that you have, you can do both the clinical and the paraclinical. And then in the follow-up, in the background, you must prevent the reoccurrence. So if you identify any particular precipitating factor, nor any factor, initiating factor that has resulted to the renal failure in this case, you must identify it. Is it clear? So you should find the pathogenesis, is it clear, such as to prevent it from reoccurring again. Is it clear? So you should prevent it from reoccurring. If it is diabetes mellitus resulting to a chronic kidney disease, you should control the diabetes mellitus. Now, also in preventing the reoccurrence, you have to know that generally in glomerular diseases, is it clear? When you have glomerular diseases, generally it is needed for a patient to be placed. So when you have glomerular disease, it is needed for a patient to be placed also on ACE inhibitor, particularly if the patient has ACE inhibitor, particularly if the patient has a chronic kidney disease. In glomerulonephritis, we say that we give steroids, but if in order to prevent in the follow-up, is it clear? In the follow-up, in order to prevent if you are in the follow-up, you want to prevent any reoccurrence of the disease. Is it clear? You need to know that the first point is that ACE inhibitors are extremely important in order to prevent reoccurrence of chronic kidney disease. Is it clear? So that's why the ACE inhibitor, the importance is that one, it is that the ACE inhibitor is nephroprotective for the other nephrons. Is it clear? It is nephroprotective for the other nephrons which are not yet damaged. The second is that it has an anti-proteinuric effect. Is it clear? It has an anti-proteinuric effect, meaning that if the patient has a proteinuria, it's going to help. And the third element is that it is the best antihypertensive in a patient that has a vascular or a glomerular chronic kidney disease. So the best antihypertensive in a patient that has a vascular or a glomerular chronic kidney disease. So you use ACE inhibitor or ARBs. Is it clear? They are going to be best in that case. But in the case of an acute kidney injury, there are etiologies of acute kidney injury. So never give in that case of acute kidney injury. Is it clear? Now the second point after that in ACE inhibitor, is it clear? The second point after that in ACE inhibitor, after the ACE inhibitor, you should prevent the reoccurrence of the anemia provided the patient has a chronic kidney disease. Prevent the reoccurrence of anemia by injecting erythropoietin to the patient. Every month. You inject erythropoietin to the patient every month. Is it clear? In anemia. Now, Also, you have to prevent also the patient from having, so in case of where you want the patient to stop having those hypocalcemia and also dystrophy, you have to give the patient daily calcium. Is it clear? So give the patient daily calcium. Is it clear in the patient? So the next element also for chronic kidney disease, we have so we have to give daily calcium with vitamin D in the patient. So those are the different elements that you have to put in mind in order to prevent the reoccurrence. Is it clear? So now those are the elements of the follow-up that you are going to use for this patient. Is it clear? So after that, after the follow-up now, the patient can be discharged and you have to reevaluate the patient later on. And then you need to know that what generally a patient that has acute kidney injury is going to regain completely the function of the kidney later on, but has a risk of another acute kidney injury provided that he has again the risk factor. He has an increase of another acute kidney injury provided he has again another risk factor. Now, in the case of chronic kidney disease, the patient is not going to regain the patient is not going to regain. So generally, chronic kidney disease is irreversible. Immediately you are at a certain state, you cannot go back behind. You can just preserve the state at which you are. Is it clear? And when the patient attain a stage 4 or stage 5, the only way to cure the patient is by using a renal transplant. Is it clear? The renal transplant. All the patient is going to be on permanent hemodialysis or peritoneal dialysis. So those are the different elements that I wanted to share with you today. Thanks for your kind attention. Please don't forget to like and subscribe for the channel SchrDbb. Thank you.